Dr. Biju.
Plenty of time to discuss today then.
How is Kerala? Is it still raining a lot there, or?
No, it has calmed down a little bit.
Oh, okay.
This December, it is still, calmed down.
Yes, yes. I think there was a lot of damage in Kerala too, right?
Yes. Till November end, one thing after the other: landslides, flooding.
Okay.
It was terrible.
Oh.
So over there in Canada, I'm not very sure where exactly you are based in Canada.
I live near Toronto, but it is a small town north of Toronto.
Okay.
But for convenience sake, we all say Toronto.
Yeah.
This is like you said Trichur, but no, this is like you say Trichur or Trivandrum, but it is like 100 kilometers from Trivandrum.
Yeah. So I mean, since December must be quite cold.
Yes, so the colder season starts sometime in October and slowly get colder, then up to March. After March, it slowly becomes warmer. But here it is everything is heated. Your house is heated, car is heated, so we don't need to worry about the cold. It's cold outside, and if you're going outside, also you put on the right clothing and you're happy.
Vara sir, I have a doubt out of curiosity. Should I ask? Please
Absolutely.
do not mind.
Yes. No, absolutely.
I see a guitar behind you. Do you play that?
Yeah, I mean, I don't play. I'm a tablist. I play mirdangam and tabla professionally.
Okay.
But guitar, I'm still learning by myself.
Okay, so soon we are going to see Dr. Vara playing guitar as a rock star.
But I play mirdangam. Mirdangam, I've completed my teacher's grade and I've played with some famous people in India. But not guitar is just a passion.
Thank you. So I think, sir, it's 8:05 and we need to just start the session. So
Yes.
Very good evening, one and all. This is Vanilla. Very good to see all of you. This is Vanilla Program Coordinator from Hyderabad Center for Palliative Care. So this week, we are left with one case presentation and Dr. Kndeepan is going to do that for us. And once Dr. Kndeepan is ready, we'll all do that. And a small announcement. So I think most of you have renamed yourself and this is the last case presentation for this certificate course in pain and palliative medicine. And I think Dr. Krishna will be telling us about some announcement which we are going to do and how we are going to go further from here. So, and please, humble request, please to keep your video cameras on throughout the session and keep your microphones muted if you're not speaking. Anytime during the session, if you have any questions, please raise your hand, ask questions. And any point of time, you can always use the chat box. We'll read out the questions for you. And with this note, I would like to hand over the session to Dr. Kndeepan. Dr. Kndeepan, are you here?
Yes. I can see him.
Yes, sir.
Dr. Kndeepan, நீங்கள் உங்களோட கேமராவை ஆன் பண்றதா ஆன் பண்ணலாம். You can start the presentation.
Dr. Kndeepan, I have started sharing the slides. You just have to tell next slide and I'll be changing the slides for you. I am going on mute. Please introduce yourself and over to you.
I think 1 minute. The presentation, the second presentation which I have sent to you, that edited one, I think. This is the first one, no? Second presentation, edited.
Oh, do you have that with you right now?
I already sent you.
One second. So did you say this is the one which I got on the WhatsApp?
Oh, so to both I have sent the both.
Okay, no, no, one second. This is the one you sent it to me on the WhatsApp. Sir, so sorry about this confusion. So meanwhile, like,
It's okay. There's no many changes, only few changes only. Okay.
okay, 1 second. So,
Dr. Kndeepan, everybody is searching for you in particular. We had a meeting to implement in Eastern District this palliative program, and they were all asking about your whereabouts. So we will give it to them soon. I think the
I'm in the teaching hospital, Vatican.
Yes, and which department do you work for there?
Oncology.
Oncology. Okay. So they will be actually contacting you for your expert advice and soon. So are we ready with the presentation? So while
I just found the presentation, sir, just loading it. Meanwhile,
sure.
Vijay sir, so sorry, and Dr. Vara, so sorry for keeping you all wait. I think it's my mistake. I have loaded the first presentation. So
not at all.
Yeah,
Not
just
at
give
all.
me a minute. I just found it.
So the good news, Dr. Biju Rahavan, for you, I mean, rest of them, sure they know. In the northern province, they have now implemented palliative care in every district. The government has implemented, and our training has come in handy for them to appoint palliative care teams.
Oh, excellent. Excellent.
Yes, I think the new governor is very much interested. The new governor of the northern province is very much interested. So it was a very happy occasion to learn that every district has now a palliative care team.
Oh, great.
And going forward, we are going to have case discussion once a month, like we did pre-pandemic. And we want to actually discuss the ground cases like we can take turns and present cases. So that is on the works now.
Okay. That's good. Yes, so the discussions are a great way of learning.
Yes. வணக்கம் நிலாக்ஷன், எப்படி இருக்கீங்க? நீங்களும் அந்த palliative care டீம்ல இருக்கிறீங்களோ?
ஆமாம் சார், நானும் இருக்கிறேன்.
ரைட். நீங்க கிளிநொச்சி தானே? சாரி, நான்
இல்ல, வவுனியா சார்.
வவுனியா. ஓகே. அண்ட் வேணி, நீங்களும் அந்த நீங்க பொலனறுவையில் இருக்கிறீங்களா என்ன? உங்களோட மியூட்ல இருக்கு.
இல்ல சார்,
முல்லைத்தீவு. நீங்கள் அந்த டீம்ல இருக்கிறீங்களோ? palliative care ஃபார்ம் பண்ணவேலே? Okay. Good. Right. Okay, Dr. Kndeepan, over to you.
Thank you. I'm Dr. Kndeepan, Medical Officer, Oncology Unit 1, Teaching Hospital, Batikalo. I'm presenting the palliative care case which I which I met in my hospital. Next, please. The key question is the difficulty in educating the patient about the cancer because of his poor understanding due to the low educational background. Next, please. The patient's Mr. X is living in the Kalmana area. His age is 62 years, male, diagnosed right side bronchial carcinoma. Next, please. Right. He was presented to us with the supraclavicular lymph nodes. After that, we did the histopathology. After that, only we revealed that there's a appearance on 7/11/2020 biopsy date from the supraclavicular lymph nodes. The appearance favors a deposit of neuroendocrine carcinoma. Before that, they have done a ultrasound scan in their hospital in Kalmane. Then only they have sent to us. We did the histopathology. After that, we ordered the CCT chest. According to CCT, central bronchial carcinoma at the right hilar region associated with multiple mediastinal nodal metastasis and two pulmonary metastasis in apical segment of right lower lobe. Next, please. Past medical history, no any past medical history. Next, please. Holistic assessment, briefly, pain and symptoms, including relevant treatment. He had mild and intermittent pain in the chest, responded to paracetamol, and intermittent cough and mild shortness of breath. He's having this for around 6 months period. Next, please. Holistic assessment brief, psychology and family concern. His education level up to grade 2. He's live with his wife. He's a fisherman, low income, very low income. One of his son is living in Middle East. Recently he went to abroad, and she's having a daughter. She married and went somewhere far from the house. And only one daughter and one son. Son is recently he went abroad. Next, please. Religion is Islam. Is believe in God. Next, please. We have started care. Then after we diagnosed, after we got the diagnosis, according to CT report, CCT report, according to that, we came to a conclusion for right bronchial carcinoma. So that we have started the chemotherapy on 3/10/2020. We have started IV paclitaxel and IV carboplatin, only one cycle. Then he developed, we stopped because of he developed the allergic reaction to the paclitaxel. It's a very allergic drug, this paclitaxel. Normally, side effect is allergic is the main side effect of this drug. Then we stopped that. Then we started the IV cisplatin and IV etoposide. 3 cycle given, then the patient left against medical advice because he don't want to continue the treatment. Then he left. Then readmitted on 18/10/2021 with the clinical signs of supravena cava obstruction. So given radiotherapy to the chest, 20 gray in 5 fraction. Then we discharged him after that. Next, please. Again, he was admitted on 18/11/2021 with a cough, hemoptysis, and mild shortness of breath. But his saturation was 99% that time. No much pain, only symptomatic intermittent pain, and it was settling with the PCM. No much problem. And he was nebulization also we are given. We managed symptomatically in the ward as he was a candidate for the palliative care from the time of diagnosis. At the time of diagnosis, he was labeled as palliative care because that in that point also he spread all the parabiotic lymph nodes and everything. He spread the disease was spread, so we can't cure that one because that's a problem, main problem. He passed away in the ward on 20/11/2021 on 21:10 hours in the ward, in our oncology ward. Next, please. Thank you. That's a case. So over to you.
Thank you, Dr. Kndeepan. So I'll just go back to your key questions so that and I'll hand it over to both Dr. Biju and Dr. Vara and the group to
thank you, Dr.
for moderation.
Yeah, thank you, Dr. Kndeepan. This is a great case and great presentation. You actually put only the important part of it. And you have asked 2 valid questions. I mean, 1 valid question, basically. I will leave it with Dr. Biju Raghavan to, start his comments. I think we can take the slide off. We know difficulty in educating the patient about cancer. That is our main here. He never had any insight, and I think Dr. Kndeepan blames it on his low education. So let's ask Dr. Biju about this.
Thank you, Dr. Mahadevan, and thank you, Dr. Kndeepan, for, as Dr. Mahadevan said, a very, very precise presentation. No unnecessary slides, to the point. So that was great. Thank you for that. And you said that from the time of diagnosis itself, this patient was meant for palliative care. So I'll come to that later. I have a few questions for some clarity on my side. He left against medical advice initially. The thought that came to my head was why he left against medical advice.
Because he don't want to continue, he can stay at the ward. That's a cisplatin. That is this is a longer duration of the around 5 hours, 6 hours, like it's a drip going. So he don't want to stay in that. He can he don't have a patient to stay in the bed. Time to time he was asking to remove the. I have to go to take the water. I have to go to the bathroom. Like that, time to time he wanted to go. He don't want to come and stay in the ward to get the treatment. He's thinking that without treatment also he can. That's no. According to his symptoms, are very low symptoms. No much difficulties in his life. So because of that, and his education level is low, because of that he thought will no any harm will come to him. Because of that, I think he
So
told, and his right that left again medical advice. He himself he don't know to write in Tamil, and his wife or someone came and they wrote, and his wife also signed. He also signed. He explained that it's difficult if you are going anyway. You have to come back. Nowhere you can't get any treatment for this type of disease. But he don't want to ask anything. He want to go, and he left, and he came back with the symptoms again. So we have treated.
I'll come to that part later. That is, he came back. I'll come to that later. The first part, from what you are telling me, it seems that he was not keen on getting the chemotherapy. Was
Yes.
this chemotherapy he was taking under pressure from somebody? I mean, did he willingly consent for this chemotherapy? If he was,
Sometimes I think he was afraid because of that first time, because of the paclitaxel, he developed the severe reactions. Because of that, I think he might be afraid to take those medicines. And the leaflet, we are giving the leaflet about the side effects of the chemotherapy drugs. In that list, there are a lot of side effects are written. Someone read for him, and he understood. Because of that, I think he was afraid of this. I think so. He's telling, I don't want to take the chemo drugs. That's the thing he's telling. He never telling why he's not telling. I wanted to go home.
right. So it seems, I mean, pardon me if I'm reading this wrong. It seems to me as if this chemo or whatever treatment he was receiving under duress, under compulsion. That's what it feels like to me. Dr. Mahadevan, would you want to comment on that?
Yes, I think, I don't think this is anything, yes, education plays a part, but here in Canada, I think Canada is one of the most literate countries in the world. So many PhDs, but it's very difficult for many of us to explain to the patients about cancer and now there is the new trend, as Dr. Kndeepan rightly said. They actually read that side effect profile. And I had a lady last week, she had a urinary tract infection. We prescribed her nitrofurantoin, but she didn't take it because she read the side effects and she ended up in the hospital with septicemia. So இது வந்து very common. I think you're right, Dr. Biju, because he must have been under compulsion from family and friends, and then he had this bad experience of getting an allergic reaction, then he doesn't want to go. But I think even when the time of diagnosis, he was a pretty advanced cancer. Is it, Dr. Kndeepan?
Yes, yes, yes.
And it is like, I think it's they said neuroendocrine tumor. So it must be a secondary, also mixed with a primary.
That is, it tells like that. But I consulted with our consultant. He told that is a type of the lung cancer.
Okay, okay.
Even
okay.
the
That
name is
explains.
like that, but it's a type of the lung cancer.
And these neuroendocrine tumors are very aggressive. And you know, in oncology, the neuroendocrine tumors can be very aggressive, especially if they occur in the lungs. So, but I think you did the right thing. You know what? You treated him again. I think என்ன நடக்கும் என்றால் அது எல்லா இடத்துலையும் இது ஸ்ரீலங்காவிலேயோ மட்டக்களப்பிலேயோ யாழ்ப்பாணத்திலேயோ ஒன்று இல்லை. There are too many patients. எங்களுக்கு கதைக்கிறதுக்கு we don't have time. அவைகளுக்கு எக்ஸ்பிளைன் பண்ணி ஒரு ஆளா இருந்து அவைகளுக்கு விளங்கப்படுத்துறதுக்கு வந்து we don't have, and there is so much misinformation in the internet which is easily gotten. சரியான இன்ஃபர்மேஷன் போறதை விட மிஸ்இன்ஃபர்மேஷன் விரைவில் பரவுது. இந்த என்ன சொல்றது வதந்தியல், they will kill you if you take the chemotherapy. There will be somebody might have write in his Facebook, they will kill you with so the trust with the doctors and nurses is secondary to their Facebook or WhatsApp. I think we have to be aggressively counter that, and by advocating the patient. அதுக்கு தான் வந்து இங்க வந்து கூட ஜிபி சிஸ்டம் இஸ் வெரி மச் டெவலப்ட் இன் பிளேசஸ் லைக் கனடா. எங்கள்கிட்ட தான் இமீடியட்டா வருவினம் ஜிபிட்ட வந்து தே வில் ட்ரஸ்ட் அஸ் அண்ட் வி டேக் டைம். இப்போ ஒரு பேஷண்ட்டுக்கு இது சொல்றேன்னா அந்த 1 ஹவருக்கு அவையில கூட்டி வந்து வித் ஃபேமிலி மீட்டிங் எவ்ரி திங் வி வில் டிஸ்கஸ் வித் தெம். ஸோ தட் இஸ் ஆல்சோ ஒன் ஆஸ்பெக்ட் we can say, but I don't think he had much pain or anything, and so it's a great case, Dr. Kndeepan. This is one of the tip of the icebergs we have. Anything, anybody else? Dr. Viduran, what is your thoughts on this? உங்களோட கருத்துக்கள் என்ன?
Yeah, I personally feel like since from the beginning it has been taken the decision as we are going to manage with palliative care. Some level we could have soothed the patient, like comforting him, and even if we can allow him to go home and let him to continue his normal activities or whatever the wish he has, and some sort of supportive mechanism could have been taken more than keeping him the hospital set up and giving too much of treatment by force or something.
We are not we are giving the drugs, then discharging. 3 days coming, the first day we are investigating, next day chemo giving, 2 days or 3 days chemo, then discharge. Then he go and he'll come back after 21 days, like that. Between that we are not keeping the patient.
Okay, even for 3 days he is not happy.
Yes, that's a problem, and he don't want to stay in the bed.
See, I think the Dr. Viduran has caught up with what I was trying to convey. I mean, whether he wanted to have this or not, because as doctors we are under no compulsion. It is not an obligation to treat a person against their will. So if they even if it is a curable cancer and we have treatment available and it is free of cost to the patient, even then we have to look into the fact whether the patient wants it or not. As doctors, we are under no obligation or compulsion to treat just because there is a patient in front of us. That was the point I was trying to convey. So if this person was desperately trying to get out of this place and willing to go at Lama, then probably to begin with, did we talk to him? Okay, he's not educated. That is fine. We can't pick and choose the educational qualification of our patients and tell him, okay, you have cancer. Probably he doesn't understand what cancer is. Okay, tell them that you have, in Tamil they say noi, you have a bad noi, and there is so and so treatment, you have to be in the hospital for 3 days, and we don't know whether it will work or not. Are you okay with it? And if he says no, I am not, then then let it be. I mean, educated or not, the patient has has some right to autonomy.
இப்ப இதே
he
கேள்வியை வந்து சொல்லுங்க டாக்டர் காண்டீபன்.
he left against medical advice. After that, after he developed the right superior vena cava obstruction symptoms, again he admitted to the same ward to treat him.
That's a different issue. We're still at the first point. He comes out of his own choice to you
And
again.
he signed that before the chemo drugs, we are getting signed from him and the relative or his wife or someone else to sign that paper. According to that paper, in the side effects and the drugs, according to side effect, all the things we are explaining and telling. After that, they are signing, then only they are giving the consent to give the chemo. After that only we are starting the drug. If they are not signing, we are not starting the chemo drugs.
Putting in a cell and agreeing for whatever, staying for 3 days in the hospital are two different things. You tell any person, when we go for loan, to take a loan in the bank, they give us one big book and we have to sign 10 places. Do we read what we are signing?
But this one is he can read. So someone, his relative, someone here read because behalf of him, and they explained to him when we gave our side explanation also, and then only he signed and his wife also signed the paper.
All right, I think I'll stop here. My only point was, if he was happy receiving whatever treatment he was receiving, he wouldn't want to flee Lama from that place. That was all the point that I was trying to say.
So here we have to ask a question.
Sorry?
No, here we have to ask a question. Are we treating the patient or are we treating our conscious? If a patient, whether he understood or not, he suffered, but then he passed away peacefully. Let me ask nursing officer, what is your, Mr. Kovalaraja, உங்களோட கருத்து என்ன இதை பற்றி? நீங்க தமிழ்லே கதைக்கலாம், no problem. உங்களோட மியூட்ல இருக்குன்னு நினைக்கிறேன். What about Vern? Yeah, Kovalaraja. நீங்கள் இதுல நீங்களும் மட்டக்களப்பிலான் இருக்கிறீங்கன்னு நினைக்கிறேன் இல்லையா? ஓ, ஹலோ, I think நீங்கள் உங்களோட கருத்து என்ன இந்த பேஷண்ட்டை பற்றின உங்களோட கருத்து என்ன?
எல்லாம் சொல்லப்பட்டது சார்.
As a nursing officer, உங்களோட பங்கு என்ன மாதிரி இருந்திருக்கு இவைகளுக்கு?
ட்ரீட்மென்ட்க்கு அவங்களோட சாய்ஸ்ன்றது வந்திருக்கு தானே.
Okay. And let me ask Dr. Puviharan, your thoughts on this. You're on mute, Dr. Puviharan.
Sorry, sir. I just
Oh, you just
sorry.
joined.
Just now I joined. Yeah.
Okay,
Sorry.
no problem. We will keep you in the pavilion for the time being.
Yeah,
Nilakshan, you're here your chance to bet.
Yes, sir. I agree with you, sir, and you, sir, that I also practicing in Sri Lanka, so I know that how we communicate with the patient. It's like it's not a two-way communication. You just say these are things you have to do, and they blindly they accepting, and then once they start the treatment and once they get a reaction or something, then they get scared, and there's no proper counseling also. I think that those are the problem, and here that what I think is he's already diagnosed as a palliative care patient, is on end stage. So what's the point of starting a chemotherapy? Is it going to be prolong his lifespan? Or so I don't think it's better to leave it as accept his and the another thing is we don't sure about what he want. The whole case, because he's passed away. Why he is not taking the medication? That's the main reason. Maybe some other reasons are there. So we need a detailed counseling also. That's my thought. Thank you, sir.
Great thoughts, Nilakshan. My question to you is, in Sri Lanka, do you have something like a social worker in hospitals?
Yes, we do have, but they are mostly, we have for social workers, but they are mainly working with psychiatric patient, and they are attached to the district secretary with the health mostly.
Okay.
So if you requested, then they may go there, but it's not like in a foreign country that
right.
they go visit. Yeah.
Okay.
All attached in the psychiatric units.
Oh.
Yeah.
All attached to the psychiatric units.
Psychiatric unit.
Okay. I think it's time to advocate for. But we have in Canada, every hospital has social workers. They go to every department before somebody get discharged or somebody want to go for LAMA. They will have to face the social worker. They are advocates, and we have palliative care social workers too. So they will advocate, they will catch us, and this is a great system. I'm not trying to introduce something, but it's a great way to think. It's not only psychiatric patients needs a social worker. Now, one other question with this patient, maybe Dr. Kndeepan can answer. What about his, you said the extended family, like the daughter is away and there is one son. How are their supports? Were you able to connect with these people, the immediate family? Mute Dr. Kndeepan.
Son is abroad. But his daughter, once she came, but I didn't have the time that day to talk with her. Once she came,
Okay.
after that she didn't come.
Okay.
Other times he was coming with his wife.
Okay. So there is another theory also. I'm not talking conspiracy theory. In places like Sri Lanka and India, where there is a two-tier system, that is, you have a private system and a government system. Some of these patients can be misled by some of the relatives saying that Mattakalappu teaching hospital in the private Colombo hospital, go to Colombo or go to Madras Apollo Hospital, you will be cured. That kind of a false information goes there. So these poor people, somehow they get money, mortgage their house or sell their land and go. That also happens. What do you think, Dr. Kndeepan? And this also, not only the private hospital, what I have seen is the alternate medicine. It's not the real alternate medicine. Alternate medicine is a great medicine, no doubt about it. Please don't misunderstand me. But the advanced cancer, somebody will say, நாங்க இந்த டாக்டர்கிட்ட போனாங்கள், வெதமாத்தியாட்ட கூட்டிட்டு போனாங்கள், அங்க கம்பஹாவிலே ஒரு ஆள் இருக்கிறார், வாங்கோ, get ready 5 lakhs from some kashayam and all that, you will be cured. So இந்த இடத்துல தான் நாங்கள் சரியான கேர்ஃபுல்லா இருக்கணும். ஏனென்றால் openly we cannot contradict them, because then we will be seen as anti alternate medicine, which we are not. We have to be careful and presenting the real facts to the patient, saying that இது நீங்கள் என்ன செய்தாலும் இது குணப்படுத்த முடியாது, வீணா காசு செலவு பண்ணாதீங்கோ என்ற இது அது சரியான கஷ்டமான நிலைமை. I can fully understand. இங்கே எங்களால செய்ய இல்லாம இருக்குது. in Canada, I know many people go to, especially in Kerala, there are centers, they claim that they will be curing everything under the sun, and they will be spending so many lakhs. I've had a patient who spent about 1 crore Indian rupees. He lived extra 3 months, that's all. But eventually he died. So we have to be careful with these, the வியாபார முதலைகளையும் நாங்கள் கொஞ்சம் கவனமா பார்த்துக்கொள்ளணும் இந்த palliative careல. Anybody on that? Mr. Fernando? Sorry, Vince Fernando.
இது சம்பந்தமான இது சம்பந்தமான என்னுடைய கருத்து என்னன்னு சொன்னால் சார், லாஸ்ட் டைம் நேற்று நான் ஒரு பேஷண்ட சந்திக்க கிடைச்சது. ஹலோ,
சொல்லுங்க, கேக்குது.
அந்த பேஷண்ட் ஒப்பீனியனும் அதுதான். தாங்கள் நிறைய செலவழிச்சிட்டோம், நிறைய லேண்டை சேல் பண்ண வேண்டி வந்துட்டு அவங்களுக்கு கவர்மெண்ட் ஹாஸ்பிட்டல் சம்பந்தமா ஒரு நெகட்டிவ் இதுதான் இருக்கு, மைண்ட்ல இருக்குது. பிரைவேட்டுக்கு போய் தான் நாங்கள் நோதனுக்கு தான் போய் நாங்கள் கூட செலவழி செய்தோம். ஜெனரல் ஹாஸ்பிட்டல் எங்களை சரியா கேர் பண்ண இல்லை. மற்றது மெடிக்கல் சைட்ல அவங்க தங்களுக்கு சரியான ஹெல்ப்பா இல்லைன்ற மாதிரி ஒரு நெகட்டிவ் இது. அவங்களுக்கு மென்டாலிட்டியான ஒரு இதை தான் நாங்கள் செய்யக்கூடியதா இருந்தது அவங்களுக்கு. அது அந்த விஷயத்தை முன் வைக்கிறேன். அந்த ஹாஸ்பிட்டல் சம்பந்தப்பட்ட ஒரு நெகட்டிவ் வந்து இலங்கையில அந்த ஒரு சில இடங்கள்ல வந்து அவங்க பிழையான ஒரு நோக்கத்தோட நீங்க சொல்ற மாதிரி வேறு பக்கத்தால டைவர்ட் பண்ணப்பட்டு இருக்கிறாங்க நிறைய பேர்.
It is not only in Sri Lanka or India, even in Canada. Canada is a one-tier system. No private hospitals, no private doctors, nothing. So what happens is, this situation, we can understand the patient and the family are desperate for a cure. They want some miracle to happen. இவையில் என்ன செய்யறா, இங்க இருந்து யுஎஸ்ஏக்கு போறது. And USA has a private healthcare system, and they think they can be cured, and they spend a lot of money from starting from the diagnosis. They do all sorts of investigations which already been done in Canada, PET scans, MRIs, everything, and they finally come to the same conclusion and finally come to the same treatment. But already they would have spent so many millions of dollars. That is not only to Sri Lanka, India. It is, we need to understand here as a palliative care people, patients, we should not blame the patients for this, because it is quite natural. If it happens to me also, I will be thinking, what are the other alternatives? So never get offended by that, but it is the proper education. மக்களுக்கு விழிப்புணர்வு கொண்டுறது வந்து எங்க எல்லோருடையும் கடமை. அதுக்கு இந்த palliative care team வந்து நிச்சயமா ஹெல்ப் பண்ணும் என்பது என்னுடைய நம்பிக்கை. என்ன சொல்றீங்க?
Sir, there is a message in the chat from Dr. Vithuran asking, can't it be advisable if the patient wishes to expand his life if he is adequate with his money?
Good, great question, Dr. Vithuran. Dr. Biju Raghavan, we'll ask your opinion.
All right. So to begin with, I'll come to that part, but in a roundabout way, because we have enough time. I heard this usage of the patient is a palliative care patient. I have talked about this topic in previous occasion also. I want to repeat it because here this is a training program on palliative care. Every patient who is suffering is a palliative care patient, whether it is a curable medical condition, cancer or non-cancer, whether it is an incurable chronic medical condition or a terminally ill patient. If there is suffering, physical, emotional, social, spiritual, it is a palliative care patient. So palliative care is something that is comfort care, is something that we provide to patients and families, irrespective of diagnosis, irrespective of stage of disease. Probably you are trying to convey that here is a patient who is terminally ill and hence is fit for end of life care. Probably that is the term you're looking for. You're mistakenly using the word palliative care. The technical term for end of life care is hospice care. So as professionals, I am practicing palliative and hospice care. In addition, I also practice pain medicine, dual specialty. So when, as now you are getting, today's the last session, you're all getting trained for practicing as palliative care physicians, apart from the other specialty you are already specialized in. So when you are practicing as palliative care physicians, it is also your responsibility to clear the misunderstandings, inadequate understandings about this field of palliative care and hospice care. You also need to be advocates of palliative care within the community, with your local government, state government, national government, among your colleagues. Your colleagues will be as much in dark about what is palliative care as the common man in the street. I have been asked by very, very experienced doctors, palliative care, what is that? Do you do acupuncture? So there is a lot of ignorance about palliative care within our own fraternity itself. So when you say that's a palliative care patient, any patient who is suffering is a palliative care patient. If you mean that this patient's diagnosis is CA, neuroendocrine tumor, stage 4, performance status 4, probably you are trying to convey this is a terminally ill patient. I have no quarrel with you trying to give palliative chemotherapy for this patient if your clinical impression was palliative chemo probably might do him some good, either improve quality of life or quantity of life, no problem. But if the person is terminally ill, please use the term hospice care or end of life care. It is different than palliative care. It's just about how you differentiate between adult medicine and pediatric medicine. It is very similar, but also very, very different, because how you approach a terminally ill patients in hospice care will be very different when you are approaching a patient in pain, breathlessness, or any other symptoms while on curative medical intervention or chronic medical care. Having said that, I will come to the question that was asked. Well, the thing is that I thought I got carried away. Can you just repeat what you were saying? What was the question that you mentioned?
Can't it be advisable if the patient wishes to expand his life if he is adequate with his money?
Right. So the expansion part, we have to understand that any treatment which is inappropriate is going to harm that person. So we have to look at the evidence base of what you are proposing to do for this patient. I can speak only from the modern medicine perspective because I have not studied alternative medicine. I can't speak for Ayurveda, Homeo, Unani, or whatever. But I can say for sure in modern medicine, evidence-based medicine would say if somebody is terminally ill, then continuing disease-focused medical intervention is inappropriate, and any inappropriate intervention will harm that person and not only will impact the quality of life, but also the quantity of life. Many of you are practicing oncology over here, and studies have come out in stage 4 lung cancer. I don't remember which journal it came up in, where they did a study where they had two arms. In one arm, stage 4 lung cancer, they provided standard cancer care. In the second arm, they provided standard cancer care plus palliative care. And what they found out was the arm which had standard cancer care plus palliative care, on an average, they lived 3 months more than the other arm. What that tells you is that palliative care or end of life care is all about increasing the quantity of your life by improving the quality of your life. When you improve the quality of your life by reducing pain, physical pain, reducing emotional stress, anxiety, anger, depression, trying to get the family together, reducing sense of isolation, taking care of social pains, and if possible, many of us are not, trained, but if you are, even provide spiritual care, not religious care, spiritual care, the existential pain, social pain, emotional pain, physical pain, all of this, if you relieve, the stress goes away and you will live longer. So, what will actually increase the quantity of life is not spending money, but getting the right appropriate care. And if somebody is terminally ill, the appropriate care is hospice care, or in simple English, end of life care. End of life care, there is no word death in it. Death is not there in end of life care because the focus is on life, physical comfort, peace of mind, dignity of life. You give that, people will live longer and happier.
Thank you, Dr. Biju. That was amazing statement too. So my take on Dr. Viduran's கேள்வி வந்து காசு இருக்குது அப்பயே நாங்கள் இதுக்கு மேல போகக்கூடாதுன்றது. அதுக்கு மேல ட்ரீட்மெண்ட் இருந்தால், இப்போ ஃபார் எக்ஸாம்பிள் இலங்கையில ஒரு ட்ரீட்மெண்ட் இல்லை, ஸ்ரீலங்காவில் ஒரு ட்ரீட்மெண்ட் இல்லை, காசு இருக்கிறவையால் நாங்கள் இந்தியாவுக்கோ இல்லை லண்டனுக்கோ போய் சேரணும் என்றால் by all means. But when somebody is diagnosed with stage 4 cancer, lung cancer, and the oncologists have clearly said இதுக்கு மேல ட்ரீட்மெண்ட் இல்லையா என்னைக்குல, நீங்கள் எங்க போனாலும் வந்து ஒன்றும் நீங்கள் அது செய்ய போறதில்லை, ட்ரீட்மெண்ட் வந்து சரியா வரப்போறதில்லை, காசு இருக்கிறதால அதை சரி வரப்போறதில்லை. I'm going to give you another example of what based on Dr. Biju Raghavan's statement. I have a patient who is now 75, but she was diagnosed with really severe form of rheumatoid arthritis. Every joint aches her, and she was tried on a lot of other medications like methotrexate, all these newer medications, immunomodulators and all that. Still she had, especially the cold season, she has so much problems. So she came and asked me, there is something in Kerala, there's Ayurveda massage and all that. Do you think it is advisable for me to go there and have this? I said, by all means, yes. Because I'm not sure, but it is not harmful. And I said, by all means, please go. So she started going there. She stays there, I think, in Kottakkal for 3 months the cold season. When she comes, she's all new person. She's completely fine with all the joint pains. She doesn't take any medications. But then the effect weans off, it becomes cold, so she goes back. So every year she goes to Kerala and get this treatment and come back. So yes, by all means, if you have money and the evidence proves, yes. But when it comes to end of life care, as Dr. Biju Raghavan rightly said, there is no other treatment by evidence. We practice evidence-based medicine. And then we say, oh, why don't you try this and why don't you try this? I think we are doing more harm. கூட நாங்கள் அந்த பேஷண்ட்டுக்கு கொடுமைதான் செய்கிற மொழிய, we are not doing any நன்மை எதுவும் செய்வதாக தெரியவில்லை. ரெண்டும் ஒரு டிஃப்ரெண்டான இது. அதுக்கு கனவேர் அன்ஃபார்ச்சுனேட்லி இந்த மாதிரி ஒரு இது வந்த உடனே நாங்கள் காசு அனுப்புறோம், நீங்கள் உடனே இந்தியாவுக்கு வெளிக்கிட்டு ஓடுங்கோண்டெல்லாம் சொல்லி அதில் கணக்க விஷயங்கள் நடக்குது. அது I think the only way we can counter these is good palliative care team, good communications with the patients, and good awareness programs and விழிப்புணர்வு talks. எல்லாரும் நீங்கள் ஒவ்வொருத்தருமே வந்து அந்த விழிப்புணர்வு, சமூகத்துல விழிப்புணர்வு வரணும். Writing articles, giving talks, and making you speak with even a private gathering. You 5 friends meet, talk about something. This is my experience there. Adathan nangal seyavanum. So I think with this we conclude today's time and the case discussion. We have some major announcements here from, I think Mr. Krishna Kumar is here. He is a man behind all this training and he is coordinating. And Vinila, over to you both. So if you have anything, we are available here.
Thank you, sir. I think we'll just give the handover to Mr. Krishna so that sir, over to you for a couple of announcements.
Yeah. Good evening to all.
தமிழ்லயே ஹரிக்கலாம் நீங்கள் கிருஷ்ணா.
Okay. நாங்கள் இன்னைக்கு ஒரு இந்த கோர்ஸின் கடைசி கட்டத்துக்கு வந்துட்டு நினைக்கிறேன். உண்மையில இன்னைக்கு இந்த கோர்ஸை கம்ப்ளீட் பண்ணினாலும் எங்களோட டீம் இந்த ஹைதராபாத் டீம்டையும் ஐஎம்ஹெச்ஓடையும் சப்போர்ட் எங்களுக்கு தொடர்ந்து கிடைக்கும். இந்த டெக்னிக்கலி நாங்கள் தொடர்ந்து இது ஒர்க் பண்ணிக்கிட்டே அவையில் எங்களுக்கு தொடர்ந்து சப்போர்ட் பண்ணுறதுக்கு ஷோ பண்ணியிருக்கணும். இந்த சூப்பர்விஷன் இந்த ஒர்க்கில் வர கைடன்ஸ் எல்லாம் தொடர்ந்து எங்களுக்கு கிடைக்கும். இந்த நிலையில நாங்கள் இந்த கோர்ஸ்ல பார்ட்டிசிபேட் பண்ணாக்கள் இந்த அட்டெண்டன்ஸ் சம்மந்தமா இதை கன்சிடர் பண்ண வேண்டி இருக்குது. இதுல என்ன ப்ராப்ளம் என்றால் இதுல இந்த எல்லா பார்ட்டிசிபென்ட்ஸும் 70% பார்க்கக்கூடிய அட்டெண்டன்ஸை எடுக்க இல்லை. இப்போ அதில் எங்களுக்கு ஒரு பிரச்சனை ஒன்று இருக்குது. அந்த பிலோ 70% அட்டெண்டன்ஸ் அட்டென்ட் பண்ண பார்ட்டிசிபென்ட்ஸுக்கு ஒரு அசைன்மெண்ட் மாதிரி ஒரு டாஸ்க்கை அசைன் பண்ணி அவையில் இந்த நாலேஜை ரிவ்யூ பண்ணி அந்த சர்டிஃபிகேட்டை வாட் பண்ணலாம்னு யோசிச்சிருக்கலாம். அப்போ நாங்கள் இதில் அடுத்த கட்டமாக நாங்கள் யார் யார் இதில் 70% பார்க்க குவாலிஃபை பண்ணாக்கள் மற்றது அட்டெண்டன்ஸ் காணாமல் இருக்கிறாக்கள் யாருன்னு சொல்லி ஒரு லிஸ்ட் ஒன்று ப்ரிப்பேர் பண்ணி இருக்கலாம். அதை ஷேர் பண்ணுவோம். அவைகளுக்கு நாங்கள் ஒரு ஆப்ஷன் கொடுக்கலாம். இந்த கோர்ஸை கம்ப்ளீட் பண்ணுறேன்னு சொன்னால், அதாவது சாட்டிஸ்ஃபேக்டரியாக கம்ப்ளீட் பண்ணுறேன்னு சொன்னால் ஒரு இதில் இந்த யூடியூப்ல இந்த கோர்ஸ் கண்டென்ட்ஸ் எல்லாம் அப்லோட் பண்ணி இருக்குது. அப்போ அதை நீங்கள் ஃபாலோ பண்ணி அதுக்கு பிறகு உங்களுக்கு ஒரு எக்ஸாம் மாதிரி ஒன்று சிட் பண்ண வேண்டி வரும். அந்த அசைன்மெண்ட் பேஸில் அதுக்கு நீங்கள் ஆன்சர் பண்ணுறது கூடாக அந்த கோர்ஸை நீங்கள் சாட்டிஸ்ஃபேக்ஷனாக கம்ப்ளீட் பண்ணலாம். மிஸ் வினிலா, you can continue. You can tell if you want to say something more.
Sorry, sir, because we are I don't follow Tamil, so we have been told them about the exam and recorded listening to the sessions and about the attendance. Is that right, sir?
Yes. I mentioned that if any participants who have below 70% of attendance, they could follow the YouTube video and can attend the exam organized by the faculties. So in that way, they could qualify this certificate course if they pass.
Thank you, sir.
I want to add one other thing before Vinila. So நாங்கள் முதல்ல இந்த palliative care program வந்து வவுனியாவிலையும் யாழ்ப்பாணத்திலையும் நாங்கள் 2 years ago துவங்கி கிட்டத்தட்ட வவுனியாவில் 200 பேஷண்ட்டுக்கு மேலே முடிச்சிட்டோம் ஹோம் கேர். டாக்டர் கௌசிகன் யாழ்ப்பாணத்தில் வந்து கிட்டத்தட்ட 240 பேஷண்ட் முடிச்சிட்டாரு. அப்போ அந்த டைமில் வந்து நாங்கள் என்ன செய்தாங்கள் என்றால் எங்களோட ஒரு வாட்ஸ்அப் குரூப் ஒன்று இருக்குது. ஸோ அந்த வாட்ஸ்அப் குரூப்பில் வந்து ஒவ்வொருத்தரும் வந்து தினமும் வந்து எங்களுக்கு டாக்டர் மதுரகன் எழுதுவார், இந்த பேஷண்ட்டுக்கு மோஃபின் 30லேருந்து 45 கூட்டலாமோ, அப்போ இந்த கேள்வியல் டவுட்டுகள் இருந்தால் நாங்கள் கிளாரிஃபை பண்ணோம். சில நேரவே அவைகளோட காய்ச்சி அப்போ அந்த இது வந்து நாங்கள் இன்னும் தொடரும் எங்களோட உதவி உங்களுக்கு கட்டாயம் இருக்கும். So I would really humbly request Dr. Biju Raghavan, if you're okay. So what I was telling is, we have a WhatsApp group. So we actually answer questions from the ground with the pay. Sometimes many doctors or nurses will have a question also, should I give morphine to this patient or should I put the catheter? So we answer them live, like every day it's a process. And every month we select one day and we have once a month, we have case discussion on ongoing patients. So we are planning to continue that. We are not going to stop here. We are going to planning to continue that as an education thing. And I would humbly request Dr. Biju Raghavan for his wholehearted support. And if you're okay, we will add your phone number to the WhatsApp group. I know we have too many WhatsApp groups already, but this is one of the best WhatsApp group I am in because it's a business like WhatsApp group. And if you are okay, we will add you also there. Thank you very much. And I will get the number from Vinila later on.
I'll be privileged to. I'll feel privileged to be part of that. Thank you.
Thank you so much. Yes, over to you, Vinila.
Yeah, I just wanted to ask, like, before we close this session, we have all the participants here. Do you have any questions, any concerns regarding the assessment, evaluation, exam, or the recordings, or anything like which you wanted to ask us? We have like Krishna, Dr. Vara, everyone with us here.
So questions and மட்டுமில்ல உங்களோட comments இந்த கோர்ஸை பற்றி உங்களோட feedback இந்த கோர்ஸை பற்றி நல்லதோ கெட்டதோ பேசுறீங்களோ இல்ல புகழ்றீங்களோ பரவாயில்லை சொன்னீங்க என்றால் நல்லா இருக்கும்.
So it is very interactive and very good training and progress certificate course. So we learn a lot of things. We don't know these type of palliative care and how we are going to treat the patient. So we get more information from this course. Even the pandemic situation, regularly you have arranged the program and the weekly we also learn a lot of things. So in addition to that, so if you possible, please send all the PowerPoint presentation is a PDF for the PowerPoint presentation mode to circulate to all the participants. Then only we can keep some information with the hard copy or the soft copy. That is easily we can go through that. That was very helpful to all the participants. Thank you.
I have all the PowerPoints with me, sir. Are you asking about the didactic sessions or the case presentations, or all put together?
Direct sessions, mainly direct session, if possible,
Okay.
to share the case.
So I have all the didactic PowerPoint presentations with me. I'm going to put them, make them into PDF. Once again, put them onto the Google Drive, and I'll be sharing it to all of you within a day or two.
Thank you very much.
Thank you.
Can we ask Mr. Vince Fernando உங்களோட feedback and comments? Yes.
You're muted. Dr. Vince Fernando, you're muted.
Hello, sorry. Hello.
Yeah.
உண்மையிலே சிறந்த ஒரு சிறப்பு ப்ரோக்ராம் அமைஞ்சிருந்தது. அப்போது என்றால் எங்கட இடத்துல வந்து இதுக்குரிய எந்த ஏற்பாடும் இதுவரையும் எங்களுக்கு இல்லை. இதுதான் எங்களுக்கு ஃபர்ஸ்ட் டைம். இப்போதான் நாங்கள் பேஷண்ட்டை கொண்டு அதுக்குரிய ஐடி பண்ணி கொண்டு இருக்கிறோம். ஒரு பேஷண்ட்டையும் எங்களுக்கு வந்து ப்ரீகேடி பேஷண்ட் நாங்கள் கூட அதுக்கு இதுக்குள்ள ஐடி பண்ணி கொண்டு இருக்கிறோம். அதுதான் எங்களுக்கு இப்போ கொஞ்சம் அவைலபிளாக இருக்குது. மற்றது எங்களுக்கு இந்த இதன் மூலமா தான் கொஞ்சம் இப்போ இந்த அடுத்த கட்டமா வில்லேஜுகள் ஒவ்வொரு வில்லேஜுகள்லையும் சில பேஷண்ட்களை வந்து கண்டறியக்கூடியதா இருக்கு இதன் மூலமா. இப்போ அண்மையில எங்களோட அந்த இதுக்குள்ள அந்த குறிப்பிட்ட எங்களோட டிஸ்ட்ரிக்ட் வைஸா உள்ளதெல்லாம் சம்பந்தமா எங்களோட டைரக்ட் இந்த பிடிஆர் எங்களோட காய்ச்சிருந்தார். இதை வந்து இன்னும் கொஞ்சம் டெவலப் பண்ற சம்பந்தமா. அப்ப அதுக்கான எங்களுக்கு மேலதிகமாக ஹெல்ப்பும் தாரா சொல்லியிருந்தார். அது எங்களுக்கு விரைவாக கிடைக்கும்னு நம்புறோம் இதன் மூலமா.
இங்க எந்த டிஸ்ட்ரிக்ட்?
மன்னார்.
மன்னார். ஓ ரைட், வெரி நைஸ். அதான் என்னென்றால் இது வந்து இப்போ நாங்கள் கணக்கு பெருசா நினைப்போம். we have to do palliative care the whole district and all that, but என்னுடைய simple approach will be start with one patient, then make it 2 patients, then 3 patients. That way we slowly expand and give them quality palliative care rather than என்ன சொல்றது, ஒரு நல்ல இதுதான். ஆனால் எங்கட பக்கத்து வீட்டில் இருக்கிற ஒரு பேஷண்ட்டுக்கு நாங்கள் போய் palliative care செய்யலாம். ஆஃபிஷியலா சில விட இந்த ஆஃபிஷியல் இதுகள் வாரத்துக்கு இட் மே டேக் டைம். ஆஃபிஷியல் ஆர்டர்ஸ் வாரத்துக்கு we can start. Palliative care can be done by everyone, but நாங்கள் வந்து we are so fortunate, we all, நான் டாக்டர் பிஜு ராகவன் எல்லாமே we are trained in palliative. So இப்போ நீங்களும் you are into our club, palliative club. So we can start with one patient. சிறுதுளி பெருவெள்ளம் ஆகும். Thank you so much. தனுஜனன் உங்களோட கருத்து சொல்லுங்க. தனுஜனன் trained nurse, ஹைதராபாத்துக்கு போய் ட்ரெயின் பண்ணப்பட்டவர் இல்லையா?
இல்ல சார், நான் ட்ரெயின் பண்ணப்பட இல்லை சார்.
ஓகே.
ஓ சார், என்ன சார் அந்த பிரசன்டேஷன் எனக்கு அந்த சான்ஸ் கிடைக்கல சார் செய்யறதுக்கு. அதான் நான் ஏன் கேட்டேன் அப்படிலாம்.
உங்களுக்கு நிறைய சான்ஸ் இருக்கு மேனி போக போக போக. ஏன்னா நாங்கள் ஒவ்வொரு மாசமும் நாங்கள் மீட் பண்ண போறோம்.
ஓகே ஓகே.
நீங்கள் உங்கள்ட்ட நிறைய கேசஸ் இருக்குது யாழ்ப்பாணத்துல.
So
Right.
therefore, Vanilla ma'am, I am asking. So I haven't get the chance to present the case study.
தனஞ்சன் நீங்கள் அந்த டேட் எடுத்த நீங்களோ முதல்ல அந்த அப்பாயின்மெண்ட்ல?
ஓ சார், எனக்கு அந்த டேட் வரையில, எனக்கு அந்த நேம்ல வரையில எனக்கு.
ஓகே, நாங்க டிஸ்கஸ் பண்றோம்.
Yeah, don't worry, Enandal, we will be having monthly case discussions. So நீங்கள் உங்களோட பேர் தான் முதல்ல இருக்குது.
The first person going to present will be Mr. Tanujan for our monthly week presentations. Sir, maybe I sincerely apologize for this. So sorry about that from my side.
Okay, ma'am. Okay.
So anybody else?
Krishna sir, will you be communicating? I mean, the organizers will discuss and freeze on one particular date for them to give so that they all have enough time to prepare for their final assessment, sir. Will you be, I mean, will you be discussing with the organizers and will you be communicating with the participants, sir? Like, how is that? Sorry, can you just
ஓகே, அந்த ப்ரெசன்டேஷன் செய்யாதாக்கள் மற்றது இந்த ஃபைனல் அசஸ்மெண்ட் செய்ய வேண்டிய ஆக்களோட நான் இருக்க தனியாக இந்த குரூப்ல டிஸ்கஸ் பண்ணி போட்டு நாங்கள் அந்த ஒரு டேட்டை ஆர்கனைஸ் பண்ணி நாங்கள் இதை அரேஞ்ச் பண்றோம்.
So it will be Zoom exam, right, sir?
Yes.
Or are we going to give any questions or so? I mean, I think we have not yet decided on the pattern of the exam. Maybe we'll come back to that as well. Yeah, thank you, sir.
So once again, I would like to extend our thanks to the Hyderabad Pain Institution. Especially Vanilla. Ellarkum theriyum, she was very, very punctual, very adamant, and I don't want to use the word adamant, but Monday morning I see the email, she's already there. So we are so fortunate to have our Hyderabad friends and especially Vanilla for this sessions. It is a long process and it was a successful process, and thank you very much, Vanilla. And also I would like to thank Dr. Biju Raghavan, who was so every time he comes the whole thing lights up. So thank you very much, and you were so lively and very practical rather than talking some theory and all that. You're very practical and you're very down to earth, and we learned a lot from you, Dr. Biju Raghavan. Thank you very much. I would also like to
may I request the other participants to please mute yourself because we are towards the end of the session, please.
So I would also like to thank certain people who are working in the background, especially Miss Sweta of Echo India. So Miss Sweta was there in the background every session, and she was doing all the technical support. So the Sweta, if you are here, I haven't seen your face. It must be Shweta Adhikari.
Good evening, sir. Good evening.
Yeah, your last name sounds very Sinhalam. We have lots of Adhikaris here in Sinhalese. Adhikari name is the singular name.
I'm from Uttarakhand, sir.
Oh, nice. Thank you so much, and very nice to see your face at last.
Thank you so much, sir.
Thanks everyone, and of course our Northern Provincial Government, Dr. Kndeepan, Provincial Director of Health Services. Thank you to Dr. Kndeepan. He's not here today. Without his support, this won't have happened. And of course, Krishna is he's like the Prime Minister. Kndeepan is like the President, and he's the Prime Minister. I mean, it's the other way around now. India, it's different. Anyway, so Krishna is the backbone of, and Krishna, we do a lot of projects with him, not only palliative care, but IMHO does a lot of projects, and he is the man to catch there. So we are very fortunate. Thank you very much, Krishna. And we will continue this. And if anybody has any questions, this is a time to ask. Otherwise, I will give this back to Ms. Vanilla to, do a conclusion.
Yeah.
Dr. Swain also here, sir.
Oh, Dr. Surain, is he here?
Yeah, the last but not
Oh, vanakkam, Dr. Surain. I didn't realize you are here. So, Dr. Surain, I missed it because I thought I was not there because you are part of us. குடும்பத்துக்குள்ளே நன்றி சொல்றது சரியில்லைன்னு மட்டும் தான் சொல்ல இல்லை. Dr. Surain, we need to hear from you.
You're muted.
I'm sorry that we had come some kind of a year-end, no, then a lot of procurement and our this new administrative thing. Then I was with the Vice Chancellor and all the meeting. So after that, and I wanted to get involved, and now that the situation here, Krishna is here, and also Dr. Kediswar and Dr. Vera, and then the present governor is very keen for implementing this palliative care, but that he doesn't want to use the name of palliative care, but then he want to implement that home care. So that is a good thing, and also now we have this is a kind of a long journey. Then we need to continue now. Maybe after you start your work, definitely we are going to have a kind of a regular meeting. I think then we have agreed, no? Then we need to get their time, like whether this Wednesday is suitable for them. And I think then most of the time, if it is suitable, and 8 to 9, then we can have kind of a meeting. And also we need to have a very active WhatsApp group, no? Then after our trainees getting into the field, they will get a lot of questions and doubts and things. So I think then at the moment we are in very fortunate thing. I hope IMHO also Canada has agreed to support now then for our next phase of the training. So this is first phase, the lectures. Second phase we have done with this case discussion. And our third things with the handful experience and the case discussion. So now maybe the so training has a good opportunity, and then learning process. So hope that you all are also enjoy, then all the medical officers and nurses involving, and we are all involving in a very even the medicine is a novel profession, but that then that this palliative care is a kind of a supreme thing. And we got very good faculty, that from Dr. Biju Raghavan is here, and then I think that we have very good faculty to guide, and then and be very pragmatic approach, then to learn, although that we are doing it this Zoom online, not maybe that face to face. So I was also able to enjoy a lot of sessions that as kind of a participant. I also able to refresh my knowledge and things by attending, and thank you for organizing. And then ECHO team, and particularly Vinila, is a superb coordination. Then always we get all on time. Then Monday that reminder comes. Then the Wednesday that all, and yes, then the ECHO team. So and then our Jonathan and all, we will. So I hope that this is a very good team. So we need to continue. And this batch, and if we can successfully finish, we could to think about for the next batch also. So this is a team effort, and then maybe the good thing for us. Thank you for the opportunity, and we will keep on going and moving.
Thank you, Dr. Suren. I know how busy you are as a Dean of the Medical Faculty. Thanks for attending many of our sessions. Yes, over to you, Vinila.
Thank you, one and all. So it's like really on behalf of Hyderabad Center for Palliative Care, I would like to thank each one of you, the organizers, the participants, Dr. Suren being a backbone of the entire training program, Mr. Krishna, Dr. Vara, and many more faculty. Like one of the faculties is here with us, Dr. Biju Raghavan and Shweta. And also on behalf of Dr. Gayatri Palat and everyone and Dr. Jonathan, so I would like to thank and congratulate on finishing this certificate course in pain and palliative care in a successful way. And it's, as Suren sir has rightly mentioned, it's a team effort. So everyone started praising me. No, it's not. I did not do this alone. I have the support of each and every one of you, and that's the reason like we could take this forward without any glitches. I know there are like some glitches in between. So, but thank you one and all. I think the later case presentation dates and time will, and the assessment date will be communicated to all the participants through Mr. Krishna. And I've shared the feedback link in the chat box for the last session one more time, requesting all of you to kindly share your feedback. It's a great, I just wanted to say this, that this is not the end, as Dr. Vara has rightly said. This is not the end, this is just the beginning. And we are going to meet more often, and you're going to see, as Dr. Shubhika has rightly mentioned, though they're trained in palliative care and they have completed this course, during their practice, they face many difficulties and the challenges, and that is the time when they will have lot of questions to ask. And as Dr. Vara has rightly mentioned, let's keep the WhatsApp group, which Dr. Viju also is going to join. I'm going to share the number with Dr. Vara. And anytime, like, we have faculties, so I'll always ready to answer your questions and help you. And this is not the end, it's just the beginning. Thank you so much, and have a good evening and a very good morning. Thank you, everyone.
Thank you.
Thank you.
Thank you, everyone.